McMullan. So Brendan will be discussing the expansion of the antibiotic guideline content to include the prevention of infection in children with immune compromise. So Brendan is a clinician scientist, a paediatric infectious diseases physician and a microbiologist. He is an associate professor in the discipline of paediatrics at the University of New South Wales and senior staff specialist in infectious diseases at Sydney Children's Hospital, Randwick. Brendan is the current chair of the Australian and New Zealand Paediatric Infectious Diseases Network and secretary of the World Society for Paediatric Infectious Diseases. Brendan's research interests include antimicrobial stewardship and resistance and bloodstream and fungal infections, especially those affecting children and young people. He is passionate about advocating for improving infection surveillance and management and antimicrobial use in children. Please join me in welcoming Brendan to the stage.
Thanks very much, Leanne. Thanks to the organisers for inviting me to speak. It's wonderful to be here, especially to speak after Crispin, who's basically warmed you all up and really covered the topic, so that I can just talk a little bit about that expansion and the paediatric involvement. I think it is fantastic that Therapeutic Guidelines has made a real effort so that our national guidelines are really applicable across the lifespan, including in sub-conditions such as immune compromise. I'd just like to echo the acknowledgement of country. This is a photo I took where I live on Gadigal lands in the territory of the Eora Nation in an area now known as Sydney. And these are my disclosures. So I will cover some of the same areas that Crispin has covered, obviously, with reference to paediatrics. But because Crispin has outlined quite a lot of the epidemiology and the clinical need for this already, I'm going to focus a little bit more on giving you some of the details and screenshots so you can get a sense of what it actually looks like. I would just echo what Crispin said, even though I'm not really going to talk to this today, although there are those recommendations for when you need that, what antibiotic do I give or what prophylaxis do I need when I'm seeing this person at 3 a.m. in emergency, there is actually quite a lot of good accessible text to read that covers some of the newer areas that I think are very valuable to become familiar with, such as when and I feel like we're swimming in MABs and tyrosine kinase inhibitors these days, so there's some good introductory information on those and how it applies to infection risk and prophylaxis. So here are some of the chapter headings and section headings in this section, and you can see just how extensive it is. So we're going to highlight a few areas today, but there are actually many different features of immune compromise, many different types, many different organism risks, and so there's quite comprehensive, even if it's not total, coverage of this topic in the new edition of Therapeutic Guidelines. So Crispin touched on the whole prednisone dilemma, and what I think is important to say is that we've actually provided some dosing advice here in the specific that covers the paediatric prednisone equivalent when we're talking about immune suppression, and that it doesn't apply to those kids who get 3 days of ready pred for an asthma exacerbation. But if they're on a different corticosteroid, what is that dose equivalent? Prednisone dose equivalent both for adults and for children, and you can see that there. Secondly, I just want to state that where possible, we've harmonised across the lifespan. So generally the advice on immune compromise related prophylaxis for children is as for adults in many of the risk group organisms and many of the topics. So that really does apply to hepatitis B, although fortunately in paediatrics that's generally less required because of the great success of hepatitis B immunisation programs, although given measles and diphtheria, we know that we can't rest on our laurels there and that remains an ongoing risk. PCP or PJP, pneumocystis jirovecii pneumonia, although I will highlight some specific dosing issues. For strongyloides, for melioidosis, so those infections of more tropical areas, and for herpes simplex virus, including using valacyclovir, which I'll get to. Now, for tuberculosis, the principles are similar, but of course the risk of disease and the phenotype of disease does differ quite substantially in children, so this guideline isn't meant to, cover that comprehensively, because the focus is on the pharmacological management for prophylaxis and treatment. So, hematologic malignancy, Crispin's touched on this already. Just to state for preaching to the choir here that in paediatrics, the epidemiology of hematologic malignancy is quite distinct from adult medicine. Acute lymphoblastic leukemia is the most common hematologic malignancy type of the acute leukemias, and that very much does influence some of the prophylaxis required. The principles are usually pretty similar for pneumocystis, but there are really quite distinct issues with antifungal prophylaxis. So to the extent that, of course, there are age-related and formulation issues, there is often delayed evidence for use of these drugs in pediatrics versus adults, although we now have pretty good evidence for most of the commonly used ones. I think it would be interesting in future editions to see recommendations for some of the newer antifungal agents that have been developed in the last 10 years. But azole interactions and chemotherapy in pediatric leukemia usually means not so much sacrificing the chemotherapy for the azole, but the other way around. So avoidance of azole antifungals as a class in many cases during periods of chemotherapy for ALL and some other malignancy types. As Crispin mentioned, there's quite an expansion of content that's applicable to solid organ malignancy and CAR cellular therapy. Failed to fall into the trap there. For kidney and liver transplants, now for adults, there's a recommendation about Toxoplasma gondii prophylaxis, and we just couldn't find consensus or good evidence in children. So we did have to fall back and recommend that local protocols be followed. And I absolutely agree with Crispin's point that we really want to achieve national consensus, and ideally that should be based on best evidence. But to some extent, in some aspects, therapeutic guidelines, like other guidelines, has had to take an incremental approach, balancing acceptability versus consensus. So there are some cases where we've had to recommend following local protocols or seeking expert advice, even though frighteningly sometimes we are those experts. In this condition in children, the duration of CMV prophylaxis varies. It does depend a little bit on the net immunosuppression, which I think is a very important point, but unfortunately also on some protocols. And so there's just a description about that, but it is usually 3 to 6 months for CMV. And there's now a letermovir regimen included for children 12 years and older who've had a kidney transplant, although there is that supplementary recommendation to seek expert advice, and some advice on oral nystatin in this group. For heart-lung transplant, there's a recommendation for children to continue pneumocystis prophylaxis for at least 12 months. So that's a little bit different from the adult recommendations, or at least 6 weeks following rejection. And once again, could not achieve that consensus on Toxoplasma gondii prophylaxis. Really recognising that this is fortunately a relatively rare condition, especially if people are managing to take their pneumocystis prophylaxis with Bactrim. And similarly for CMV and nystatin as for kidney transplant. Now for the human stem cell transplant, allogeneic transplants, there's a recommendation for using letermovir in adults as prophylaxis. with specific provisos around that. And now this is not funded on the PBS for children with this condition, although has now been approved by the FDA in the US. And so, and there is some evidence, limited evidence around this. So there is now a consideration in the therapeutic guidelines to use letermovir as a primary prophylaxis strategy, while the preemptive treatment strategy that's kind of mainstream is still acknowledged to be the usual strategy. But what I like about this recommendation is it does sort of front and centre put that safety proviso that unlike using ganciclovir, for example, or valganciclovir, if you're going to use letermovir prophylaxis that doesn't have any preventive therapy against HSV or varicella zoster virus, so you need that additional prophylaxis of that if required. So mold-active prophylaxis, I mentioned this is a little bit different in kids with malignancy. I think that the same can be, there are some similar caveats with stem cell transplant, but just noting that there are some divergent recommendations in the duration of therapy from pediatrics versus adults. Again, this is often based on sort of historical trial protocols rather than randomized control trials, and highlights one of those evidence gaps. But I just also want to note that there are age-specific considerations for revaccination post-transplant as per the Australian Immunisation Handbook. And again, I think a helpful feature of these guidelines is where required, it does report on what's out of scope and where to get that information. For example, consulting the Australian Immunisation Handbook, which has also coincidentally, over the last year or so, massively updated its immune compromise-based recommendations. So, delving into details a little bit for pneumocystis prophylaxis, there was intense debate about what to put in terms of the trimethoprim sulfamethoxazole regimen. And people will probably know that's because there are about 100 different regimens and all of them work, provided you take them. So we did have to do a little bit of consensus gathering and looking around various guidelines to come up with some sensible regimens that we thought were practical, reasonably common and fit for purpose. And this is what we've come up with. So but you can basically just, we're not quite at the stage where you just need a bottle in the room with the patient. But there's some flexibility with dosing and some sensible regimens presented here. The alternative to, if you can't use trimethoprim sulfamethoxazole, is a little bit more complex. But once again, we did consider what's given, we did consider the evidence and came up with some regimens that could be used when the first-line therapy is contraindicated. Importantly, including the intravenous pentamidine that's given to children and is, I understand, reasonably rarely used in adult medicine. So it's practical and it matches what some of those units are using, but now with a national consensus recommendation. Mold-active prophylaxis, I've mentioned the challenges already, but I just want to kind of highlight some of the issues there in terms of how we approach it practically. So it means that we often use echinocandins for mold-active prophylaxis, and Crispin mentioned using it for yeast-active prophylaxis before. In children, we may well use it for mold-active prophylaxis where azoles are contraindicated, but of course where you can use azoles, they're often the preferred agent. There are considerations of the child's age. Drug interactions are crucial, as are the patient's ability to tolerate the formulation and consideration of drug adverse effects. So just to note that we've provided age, or the guidelines, have provided age and weight-based dosing, intravenous and oral dosing, so you can see some recommendations there for caspofungin or micafungin, which are fairly commonly used echinocandins in this setting. Posaconazole and voriconazole with IV and oral options provided, And in this edition, we don't yet have recommendations for resofungin or olorifim or anything, but maybe in a future edition. For yeast-active prophylaxis, fluconazole is really the mainstream. So even though you can use echinocandins, we've made that recommendation for practical fluconazole dosing. And then moving on to viruses, so HSV prophylaxis. This time, acyclovir and valacyclovir oral therapy are given equal weighting, given the pharmacology and increasing experience with using that valacyclovir and managing sort of the non-syrup formulations with rounding doses and appropriate dispersal of contents. But also intravenous acyclovir dosing for children who can't tolerate oral therapy. So really designed to be practical. So you can see that here. And I mentioned the sort of formulation consideration issue. So you can see this sort of link to PBS information, and there's also information on the sort of don't rush to crush. You're probably going to highlight that partnership elsewhere in the meeting, so I won't preempt that. But there is information that's very helpful on formulation and management, and when you can crush a pill or not disperse a capsule. Neisseria meningitidis prophylaxis I'll just touch on briefly. So the preferred regimen is phenoxymethyl penicillin or amoxicillin, so similar to adults, but there was an azithromycin alternative as a practical approach for children with severe penicillin hypersensitivity. So ideally not using ciprofloxacin. Just to kind of finish up, so with the new content, as I've said, the aim was really, where possible, to make the paediatric recommendations be as easy to use as possible, as evidence-based or consensus-based if we couldn't reach evidence, as possible. There are some key differences, but where those exist, those were made for good reason, based on pharmacology, based on epidemiology, based on formulation. But even in that case, we've tried to mirror with other reputable and evidence-based guidelines, such as the new Australian neutropenic fever guidelines, such as referring to information in the Australian Immunisation Handbook, and trying to take account of other national and local guidelines, as well as a pretty robust consensus process and feedback. And the other thing is that post-launch feedback remains welcome. So there's certainly capacity to take that feedback on and review things for the future. So I'll stop there, and thanks again.
Thanks so much, Brendan. That was great. Does anyone have a question for Brendan about his presentation? We have one there. Thanks, Madeline.
Thanks so much. Thanks, Brendan, for a really interesting presentation. And Crispin, this question's partly to yourself as well. My name's Christoph. I'm a trainee coming into this wonderful specialty. And my question with regard to the development of the guidelines is how you balance cost and recommendations for new, potentially very effective medications that are not on the PBS versus access to older medications that are perhaps general schedule, and whether those debates take place in the room, how you balance those recommendations. Yeah. And thinking also to other parts of the therapeutic guidelines with regard to fosfomycin, for instance, which is still not PBS subsidised but is highly recommended in urinary tract infections, for instance.
Yeah, I might start to answer that question and then hand to Crispin to say that, I think that is a genuine issue of importance, and it certainly is considered. I mean, I think it depends a little bit on the specific drug and infection and issue. I think probably it's fair to say that, efficacy and evidence is the prime driver of a recommendation, but it's important to consider availability, acceptability, cost, and that certainly has influenced, a number of issues in the guideline. For example, lincomycin recommendations along with clindamycin, because recognising that certain things are used elsewhere. But I'll hand to Crispin.
Very much the same. I think certainly when there are agents with similar efficacy, we would prioritise the cheaper and more readily available options higher up the list. They get a 1 recommendation rather than a 2 or a 3. There are some challenges when there's a new agent. I think some of the anti-CMV drugs are a really good example that are horrendously expensive and have limited availability, but probably do actually have better efficacy as well. And that was sort of my point about, is the purpose of therapeutic guidelines to lead the debate, or is it something we actually want to practically introduce and be able to actually do for our patients? And that's a tension that I don't think there's a totally correct answer for.
I'll just add as well, I think you articulated it well, but sometimes it's also being a leader, because the PBAC and the TGA would only approve certain things. And in fact, after the last version of the antibiotic guidelines, the change to repeats and so on, the PBS, was led by the guidelines. So it is a real tension that you need to consider, the leadership role versus like what is in reality at the time.
And I guess on that point as well, is part of your audience actually drugs committees within hospitals, considering your particular
Yes.
target population?
Yes, so we have relationships with the various, I can't remember, like New South Wales, what are the... safety and so on. And so we have an ongoing relationship. We also lean on our expert group as well, but we're definitely developing a larger environment where we can have this communication and also flag to the relevant custodians of imprests and what have you, formularies, so they have an understanding. But this is kind of quite a new relationship as we've been building resources within therapeutic guidelines.
It'd be fair to say that on the other end, from a hospital drug committee, that we, certainly our hospital drug committee, if there's a positive therapeutic guidelines recommendation, then we won't have to submit any further evidence for an application, for example. And so that it very much helps from that point of view. It doesn't always still work, because it might be a positive recommendation for an agent that's just heinously expensive and we still can't use it. But it certainly suffices for the evidence basis for a request for a single patient usage or a defined population usage drug.
And I think we try to, if it's an outrageously expensive thing, we try to kind of sprinkle in a warning to be like, it's not available on the PBS. I've just worked on an update to the HIV PEP topic. Is it the PEP? PEP or PrEP? PEP. And I think we were talking about how the 2 drug agents are cheap, relatively speaking, whereas the 3 aren't, and they're available as generics. So you have to develop some language to kind of flag that as well. And